Same time, so I got to spoil that man and root him for every other tech after he left. For 2 years, I got to just cater to him.
Liver. Yeah. This is the bowel. So the liver makes the bile, it goes into the gallbladder, and then it leaves the gallbladder and goes down into the common bile duct. Yes. So your gallbladder connects into the common bile duct, and your pancreas connects into your common bile duct. But the pancreas is in the back. It's retroperitoneal. Exactly, and that's exactly where it was. So right at the bottom of it. The chest open, and this is actually the lung right here.
It looks like a damaged lung.
It is. This is a damaged lung from trauma. Once you get stones and symptoms, then we need to have a level.
That's your favorite surgery, right?
That's my favorite too. I did 4 gallbladders yesterday and I did an happy this morning. What you want to do is you want to grab it near the back without locking. You want to turn the needle down and then lock it, okay? That way nobody can get poked. Do you know how to tie?
I don't know how to do it.
It might be hard if you've never done it before. You hold a suture like this, okay? And you make a bridge, okay? And then you go with your finger and you bring it to yourself. It's a lot harder than it looks, okay? This suture has a lot of memory, so even though I push it down, it won't stay. So I'm going to do another forward throw, and then it'll go down a little bit. And then it's a loose one, and then a backward throw to lock it. Okay. Cut that. Excellent. Okay. There you go, and here you go.
That's okay.
You're very welcome. And lock it, okay? Do you have another big one?
I do. Just be careful. I got a sharp. Okay. That's the last of my big.
That's fine. Okay. So anyway, I have control of the blood supply, and now I can cut in between. Yep. So you have a Mets. We'll use this one. This is a curve one. Yeah, that's more for suture. Okay. So I'm going to cut in between. Okay. So now that's free. There you go. Thank you. Okay. Now it's just a matter of getting the other attachments, okay, which I can just use usually cautery for.
Here's the. That's all I mean right now. You can staple as well, especially where the blood is. See the opening to the artery? You can use that. I'm just going to cut that down. This is just a membrane. Holds the spleen back. Okay. So now your spleen is free. Okay. Pass it off. We just did a splenectomy. Fresh frozen, Doc?
Fresh frozen.
Fresh frozen herd.
Exactly.
This is critical as far as you can actually make it into the side, but also on the back end.
Thank you.
Enough oxygen, respiratory function, something like that. So those are good signs. Once you get there, all you're doing is placing manual pressure on that vessel trying to slide the water. We're getting them out. However, this is important though because this is the role that we, between us, between the foresight, this is one of the kind of our bread and butter. And
but also get to cover. Can you treat yourself? Right? Can you apply self-aid? Okay. So, although we're medical people, right? Everybody has their own sort of med kit. So you always want the, as long as you have fire seniority, you can get to your patient, you can drag them if they can't treat themselves, get to cover, they're not responding to you, right? You're dragging them, you're getting them to cover, and you get to...
What do you guys think is coming next? Yep, twisting the windlass, right? So now we're twisting the windlass. You guys want to actually practice on each other? We'll do that. All right. So we'll take a volunteer.
The next thing you spin the windlass. Spin it. I'll tell you when to stop. And remember the purpose of this is to stop the bleeding, but how do you know it? We don't have time for that. We have that really. But that's kind of like the purpose.
You're going to see my pain face. You got yours backwards. That's good to go. All right. So this is going to be really painful for your patient, by the way. I'm sure you guys know, right?
So I'm an ATLS, ACLS instructor also. So when you're going through those trainings, sometimes we focus on certain things. This is a little bit different. You imagine you're out in that field environment. You're probably running solo on the medical side, and you maybe have multiple casualties at the same time. So you're going to hit the big things that are, prevent the things that are going to kill the patient the quickest. So that's what you're going to focus on. So we may do things a little bit different than what you'd be trained to do in a hospital where you have unlimited resources and probably unlimited manpower in a given situation.
Reset. You came from here, you get them off the X. Every time we move a patient, we have to recess all of our interventions that we have performed. So I would check the tourniquet for his arterial breathe. Still good. Bleeding is sustained. Then I'll continue on to the March algorithm. So M, we're going to do blood sweeps. We're going to check if there's any other hemorrhage we didn't see while we were getting shot at or getting fired superiority. We're going to go up here, stop big pipes, little pipes, start from the deck. Already stopped the bleeding for this, so I'll check the other leg. Nothing else. So now I move on to A.
Going to be airway. So what he's going to do is go ahead and see not the quality of respirations, but is he actually getting air into his respiratory tract. So you see he's listening, he's looking, he's checking for chest rise and fall. He can do maneuvers like head tilt chin lift, jaw thrust maneuver, and such.
And the major thing that we do in the field that is non-invasive to the patient, but it will also be good to have inside already, just in case they go unconscious and they lose their airway, and we don't know if they lose their airway while we're moving on to the other assessments. We'll do an FBA, so it keeps an airway on them all the time. So for the nasal canal, it's different directions. So for the right nostril, we just go straight down. For the left one, we have to start up like this, happy face, and then twist it down to ITELs are a little bit more invasive. The patient has to be severely unconscious. I have used this once for my CPR patients. It works well. You just lube it up. And then another incision. And while I'm holding the incision there, I'm going to get my key ready. Get it in there, remove the scalpel. Make sure you don't drop this or make sure it's closed. Oh, I didn't cut deep enough. Oh well. Well, if I did cut it deep enough, you get your insertion and you start sliding it in.
Once we have our crike in place, there's a couple of things we're looking for. So if we're out on the X, we're obviously going to look for misting. We're going to look for improved respiratory.
If you don't see improvement, check for an exit roll. So you're going to lock roll them. If I had another person, one person would get on the legs, another person would get up on the chest, and you just interlock across the arms. And then after C, we move on to double H's, head and hypothermia. We're checking the head, checking if they have any TBIs, if they have any fracture or skull fracture injuries, if they have any fluid coming out of their ears, nose, if we need to take C-spine precautions if we haven't already, and then hypothermia, keeping them warm. You're not trying to, we're staying on the ship is we're trying to warm the patient, not the ship. And then we're going to move on to the secondary assessment. After you've done with the March algorithm and saved their life, you're going to move on to secondary. So pause, pain, antibiotics. So when you push more of your meds, any secondary wounds, so like cuts, anything else like that, and then broken bones, you would splint here at the
Yeah, so, and I have...
And when people have that, what are having your that you have to live. I have a high And I'm not just somebody
you catch your medical degree. Some people when they're younger, they're like, I don't want to do that. It's too small. Like, they want to.
Did I say that? Yes, because well, we actually.
That's my number. Help, you want to know more, I got you.